apologies today. I think it must be the time of the year. So we have apologies from Fiona Burton. Ellie, lovely for you to deputise, thank you. We have apologies from Oliver Koffler, Michael Cox, Tim Crook, Mike Flaxman, Phil Gilbert, Ollie Hisco, Bharti Patel, Carolyn Pickering, Jeremy Shearman, Sue Warner and Robert White. Just before we move on though, because I know it is her last or would have been her last Council of Governors meeting, I'd just like to publicly thank Sue Warner, who's been one of our staff governors and a senior nurse on our community team. Can I ask everyone to go on to mute, please? Sue has been an absolutely outstanding governor for us for many years, as well as one of our senior nurses. So Sue, thank you for your service on the Council of Governors. Sue's actually leaving Swift, hence she's needing to stand down. Sarah, your hand is up before I move off of apologies.
Sorry, I just wanted to add we have also received apologies from David G, Matthew Gain, Manu, Yasmin Pramjit and potentially Jean Arrowsmith.
So it's a select crew that's with us today. David G is unwell at the moment. So David, if you're subsequently watching this on YouTube, we wish you well and a speedy recovery. Any declarations of qualification for office or declarations of interest, please raise a digital hand. I can't see any digital hands raised, so I'll allow the public record to stand. And the minutes of the meeting held on the 8th of May, are there any points of accuracy on those? Could you raise a digital hand for me, please? Otherwise, I'll take them as an accurate record. And again, I can't see, I can't see a digital hand raised on those, so I'll take those as accurate as well. The matters arising and action points are on page 16 of our pack. The first was for Verity to ensure that the Radiation Protection Committee meeting invitations went out. Verity, thank you for sorting that. Then Adam to liaise with Basco, I think, to draft a letter to the ICB about the ongoing clinical concerns regarding acute stroke services in Coventry and Warwickshire and the delayed service review. Adam, can you brief us on where we are with that?
Yeah, it was Martin Sandler actually, rather than Bhaskar, and we did contact the ICB. We've asked for a further conversation on that. So we shared our concerns, particularly around data relating to review. We had been promised further information about the review work they had done and the data it was based on. We haven't had anything back in the last month or so, so we are arranging a follow-up discussion with the ICB on that.
Okay. Thank you, Adam. Please do keep us briefed because obviously stroke services are a very real concern for members of the public as well as our teams. And then we had an update on the community integrator service, which we'll come back to later, Adam.
Yes, so I think at general purposes committee the decision was taken actually to remove this from the agenda, yeah. But Jack Foster is providing a written update instead. Okay,
super. Thank you very much. Are there any other matters arising that colleagues feel I might have missed? Okay, we'll move on then to the Trust Chair's remarks. Adam will no doubt touch on it, as will Glenn later, but this is an extremely busy time for the NHS generally in a time of real change. For Swift in particular, the level of increase in demand into our services, as many governors are aware, is probably best evidenced by the emergency department's increased demand over the last 5 years. At Warwick Hospital, we've seen around a 35% increase in demand over the last 5 years. That compares with about a 6% increase at the George Eliot Hospital in Nuneaton and about a 5% decline at UHCW. That has placed enormous pressures on our ED department in particular, at a time where our funding arrangements have been pretty static on a block arrangement in quite a peculiar way to the Coventry and Warwickshire system. That block payment really hasn't changed that much, certainly nowhere near to make up for the increased demand into ED. And that's caused us real challenges financially and from a performance perspective. So I would really like to thank all of the teams, because it does then become a whole hospital issue. All of the teams, particularly the team in ED, for the work that they do day in, day out, coping with those phenomenal increases in demand. We should remember that across Warwickshire, our population is growing, and as one will see from all of the houses going up around us, whether it's in Kenilworth, Leamington, or South Warwickshire rurally, that we will continue to see the level of increased demand coming through. And therefore, I'm absolutely delighted with the level of estates work which has been going on. For those of you who have recently visited the Warwick site, it's wonderful to see the new reception finally just about to open, and down at Shipston, the Ellen Badger Hospital, and that fantastic new facility which we've laid down for the citizens there and for citizens in South Warwickshire generally. Glenn has been doing some absolutely phenomenal work at the national level. So as you'll be aware, we have lost Glenn significantly as he's become the National Finance Reset Director. And so thanks to Adam for the taking up of the burden of the acting chief executive role for George Eliot and Swift. And as we approach and look forward into the challenges that we've got for the future, we are unifying and sharing the leadership over George Eliot and Swift, and that work has been done and is in the process of being implemented. So we will future-proof both Swift and George Eliot. We have had the National Operating Framework come out over the last couple of weeks. At its simplest, that's a league table which allows trusts to be compared. It's caused a degree of fuss, I think, among some colleagues within the NHS who don't like league tables. Personally, I'm a big fan of transparency of performance within the NHS, because the level of variation in terms of performance is so enormous across acutes of similar characteristics. Swift, members of the public will be pleased to learn, was ranked 25th out of 134, so amongst the very top. And our performance was really only held back by our cancer performance, where we rely heavily on UHCW under a service level agreement for the provision of oncologists. So overall, a time of very real change, an awful lot going on. I'm immensely grateful for our frontline teams and the work that they do, as well as the leadership at Swift for the leadership they provide during these challenging and changing times. That's really it in terms of Chair's remarks for me. So I suggest we move on to the assurance items and allow questions at the end. So we've had a few Governor requested assurance items, and the first is partly related to what I've touched on there, how the Trust maximises its opportunities from the 10-year health plan for the NHS. Glenn.
Thank you, Russell, and thank you for asking me to come and talk about this. It's always nice to be involved in the Council of Governors meeting as opposed to some of the other things I've been involved in at the moment. I'm going to share with you just a few slides that help to get the message over about some of the things that we're doing. Hopefully you can see those slides now. I'll go to the beginning of the slides. There we go. Yeah, as Russell said, the Financial Reset and Accountability Director role has been a little bit of a preoccupation for me over the last few months. And in doing that, we're putting in place the elements of the 10-year health plan that was launched earlier this year. And for those of you who followed this closely, you'll know that the original piece of work from Lord Darcy last year set the scene for the need to look at the NHS in a different fashion. Lord Darcy very much focused on the health of the nation, actually, and pointed out that whilst much of that is not the NHS's to deal with. There are quite a few things that are for the NHS to deal with. So we absolutely need to ensure that we play a much bigger role in prevention. We need to ensure that we deliver better access to patients, particularly shifting more activity into patients' homes. So those 3 mission shifts came out of that plan: care close to home, use of digital, and a prevention focus. And alongside that, we've been seeking to reduce the size of the centre, which has been a piece of work I've been quite heavily involved in, and to shift more resource and focus into neighbourhoods and communities, and to do so using technology. As part of that, there were a number of work streams identified to implement the plan, and they're set out there. I won't go through every single one of them. But one thing that's been quite helpful in the way that this has been approached by the transition team is that we're trying to do all of this through a work of co-production with particularly with chief executives in the service and other partners. So I've been leading on the oversight and the financial, the 2 green boxes there to ensure that we work with chief execs to put those things in place. I'll talk a little bit more about the component parts of that. I think though the big areas that really will matter more to patients will be the neighbourhood developments, designing new contracts that ensure patients are treated closer to home, and also that prevention focus. There's some bills that were going through the House of Lords, but there's some important changes in the way that we behave as an NHS to ensure that we spend more time looking at those things. And a whole range of other things on that slide. I suppose the other one to point out from all of that is trying to ensure the NHS app is a kind of digital first solution for patients, that those who can use the app can access more services, alter their appointment dates, get advice and support, and to ensure that we don't exclude other members of the community who can't use digital devices, to ensure that there's access routes for them also. And there's also a big thing, the bottom right-hand corner there, a big thing about how we can use this really unique service, which is a comprehensive service across a whole nation, to invest more in genomics, life sciences and research, and potentially to bring more resources through pharma into the country to help to boost the economy. And the NHS is uniquely placed to do that. So one of the things that I've been looking at is this new operating model. As I said a moment ago, reducing the size of the centre, there's around about 25,000 people employed through Department of Health and NHS England in various roles. That's quite a bit bigger than it used to be a few years ago. So we've set out to halve the number of people that are employed in those roles, and that's been quite a challenging thing to do. Probably the most significant element of that will be the coming together of the Department of Health and NHS England. Previously, Department of Health was very much facing ministers and the government, and NHS England was very much facing the service. Having worked in that organisation for the last few months, it's been really clear to me the amount of duplication and man-marking that goes on as a result of that. So bringing the two together is logical. That obviously will require statute. So there are things that are being done to ensure that we can make those changes. 1 or 2 other areas of statute that will be required to bring about the plan, but there's many other things that don't require statute. So linked to that, we've been redesigning and repurposing regions, and an important thing for trusts like Swift here is that regions will now have oversight of provider performance and finance, as opposed to integrated care boards doing so, because integrated care boards are now very much focused on commissioning. And for me, that's a really important manoeuvre to ensure that the role of ICBs is to look at managing demand and changing demand patterns and moving activity out of hospital. And from a commissioning perspective, ensure that sufficient capacity is commissioned to deliver that. And then secondly, for providers, our focus will be much more on the effectiveness, cost of delivery, managing the efficiency of the NHS. And so that chart hopefully sets out those slightly different functions. And what we've done over the last few weeks is firstly implemented what's called model ICB and then model region, which set out those operating models. The ICB challenge has been the first thing to put in place in this kind of national jigsaw. On the left-hand side, there you can see the 42 ICBs that existed prior to these changes, and on the right-hand side, it says potential. Those have all been now signed off. We have 26 either individual ICBs or clusters of ICBs. So still those ICBs in the background, but working with single leadership teams. And it may be that in the course of time, we move to a situation where they are formally merged, but at this stage, they are clusters. And you can see the Midlands region, the green part of that map, is an area where there's quite a lot of change happening. And we really welcome this from a group perspective, moving from 11 to 5 groupings within our region. And what's particularly neat about that is that if you look at the map, then there's a lovely little neatness for the group shape that means that we will now be working as a group with one ICB leadership team across Coventry, Warwickshire, Hereford and Worcester. And what these changes have been able to do nationally is move from running costs per head of population that ranged from anywhere from about £24 per head to £51 per head to everyone operating within a £19 per head operating limit. And obviously by doing that, we are freeing up more investment to frontline services. And this is a description of what's happened within our local ICB, things that they're focusing on more, that kind of population health management commissioning role, things that they're sharing between them and the Hereford and Worcester ICB and reducing their running costs. Some things moving to providers, things that providers generally have actually already been doing, but have been, in some cases, man-marked by ICBs to do so, things like workforce planning, green planning, technology. And then some things moving to regional level. And at the bottom there, some things that are statutory responsibilities of the ICB that we've been reviewing. And a good example of that is continuing healthcare. We've done a piece of work nationally to look at the cost of continuing healthcare, which shows that if every ICB operated at a level that was as good as the best in the NHS, we would save £2.3 billion as an NHS. So we've issued some best practice guidance on that. As Russell said, one of the other important elements around this has been moving to a situation where there's a rules-based, transparent system of oversight. And there's oversight of ICBs and their new strategic commissioning role, but oversight of providers, which has been depicted in the league tables that Russell referenced. Those league tables are based on a set of numbers which we've been using for a number of years in the NHS. They look at quality, safety, patient experience, staff experience. And quite rightly, we are showing to the public how each individual organisation in the NHS is performing. That sets 4 different segments of performance for providers, and we will be linking those segments, with one being the best performing, maximum autonomy, be linking those to freedoms and linking those to something I'll talk about in a moment, a new foundation trust regime that will be implemented. Those organisations in segment 4 will go through a capability assessment to determine whether some of them should be in segment 5, and that segment 5 is a special measures segment, which is called the Provider Improvement Programme, where they'll be given support, where they'll be given challenge, and in some cases we may need to intervene and reconfigure those organisations, and we will be doing so by setting out a new framework for improvement across the NHS. The website, if members of the Council of Governors had a chance to look at it, I would encourage you to do so. If you go into NHS England and look for the oversight framework, there's a public-facing tool that shows you the performance of every single trust in the NHS. There are generally more indicators for acute trusts. And as Russell said, we come 25th out of all trusts in that league table. Actually, the top of the league table is dominated by specialist trusts that don't have as many challenges as your average district general hospital. So I'm quite pleased with where we are in all of that. The example measure that we're looking at here is the people and workforce indicator. And as you can see, it shows you where your trust is compared to all the trusts in the country. But it has been challenging. There's been a degree of challenge from the media and the public about how those league tables are pulled together. And each year we will set out some new parameters for league tables, which we've started to do right now, particularly focusing our league tables more on some of those things we're trying to change. So some of the care outside of hospitals, some of the focus on prevention. And so my final slide looks from a group or a trust perspective on the opportunities that are here. And probably the biggest opportunity is to move into what's called integrated healthcare organisation mode. You hopefully recognise that top right-hand picture, which is our group strategy, the bottom one being the integrated healthcare organisation model, which was developed in Canterbury, New Zealand. This integrated healthcare organisation opportunity is very much for trusts like ours to become the integrator, to receive funding for looking after the entire population in an area, for focusing on prevention, etc. What we've determined is that it's not about a new organisational form. The organisational form will be that of a foundation trust, but a small high-performing group of foundation trusts will be allowed to take on these contracts for being an integrated healthcare organisation, and there'll be longer duration contracts, there'll be more outcomes and prevention focused, and it will be about how those organisations work with partners. So we are really pleased that our strategy that we've had for a number of years now is absolutely consistent with the things that are in the 10-year health plan. But one thing we need to do immediately is to be reauthorised as foundation trust. So this one, the view of the politicians is that, having seen all the changes over the last few years, there are now some foundation trusts that probably wouldn't be authorised because they're not performing at the highest level. So based on that oversight framework, where we are in league tables, those are in segment 1 or segment 2, which includes us. And those who have a CQC rating of either outstanding or good, which includes us, will be given the opportunity to be reauthorised in a first pipeline, which will be live from the start of next year. And a small subset of those will be allowed to put themselves forward to hold those IHO contracts. But an important part of wanting to be in a new FT is about how we will be incentivised and the freedoms will be given as an organisation. So we're setting those out and working on those at the moment nationally. It hopefully will include access to capital, maybe access to different forms of capital. It will also include a new tariff regime, which we are developing, which will appropriately reward organisations who do the activity. So the thing that Russell referenced right at the start of the meeting, we are in a block contract that's not been reset for a number of years now. And if you look at the volumes that we are now seeing, we would secure additional income for doing those volumes. So that new financial regime, which is very much a work in progress for me at the moment, is something that we really want to get in place. And then as an IHO, I think it would be for us about demonstrating how we can work to deliver the aims of the 10-year health plan, and in particular how we work with primary care. Neighbourhoods will be the new delivery model, so we will need to align our services more to primary care leadership at neighbourhood levels so that we can pull this off and deliver the best things for our patients. One other thing that I just wanted to touch on before happy to take questions, Russell, is an element of the new FT model that would need legislation would be to remove governors. That's certainly not my choice, but is set out in the legislation at the moment. That will need to go through a process where it becomes legislation. But I just wanted to say here now that as an FT, as an organisation that would want to hold an integrated healthcare organisation, we need to find a way of continuing to engage with our local public. So we would want to come up with a version of that. It's obviously something we need to give some more thought to and have more conversations with you as we move forward. At the moment, it looks like legislation would be April 2027, so we've got a little bit of time to work on it. So that's hopefully a useful overview, Russell.
No, fantastic, Glenn. And you didn't mention them, but equally, HealthWatch, we would want to find a way of continuing to engage with a new version of HealthWatch where the responsibilities are shifting to the ICB. I'd just like to thank Chris Bain and everyone at HealthWatch Warwickshire. I think they do an absolutely outstanding job for our citizens. Any questions or perspectives to Glenn? We've got a few moments before we need to move on. Kieran? You're on mute, Kieran.
Don't worry.
Okay, are you okay, Kieran? Fine.
Yeah.
Okay. Any other questions or perspectives? Well, Glenn, please do continue to keep us briefed. Leslie?
I just wanted to pick you up on something you said about continuing healthcare. You said you wanted to learn from the best. Is that in terms of the delivery or in terms of the financial position that they hold?
Actually, from what we can see, it's a combination of both. Obviously, what we need to ensure is that every pound we spend is appropriately spent on delivering the best care to patients. But what you can see from looking at that really wide variation in spend is that in some parts of the country, packages of care have not been reviewed. Dare I say, in some parts of the country, payment was being made where patients were no longer alive. So I think there is an absolute need to ensure that the money is spent on the right support for patients. But also probably one of the best practice areas is something that I think we're quite good at locally, which is ensuring that we keep people in the acute setting for the minimum period possible, so that we get people home, we provide that support in home, and then they don't need those ongoing packages of care. So some of this is about effective flow in the system that avoids the deterioration that often results in needing to put expensive care packages in place. So I think on this one particularly, value is quite consistent with good quality services to patients.
Okay, thank you.
Thank you, Leslie. Thank you, Glenn. And Kieran, your hand's gone up again.
Hopefully I'm unmuted it now. You were talking about neighbourhoods, Glenn. How big are what's the size of the neighbourhoods from what they were to what they're going to be?
Yeah, so there's a discussion going on at the moment with primary care colleagues about how we define that. It will be different in different parts of the country, and I think the discussion has been around 50,000 populations as being an appropriate scale for neighbourhood. The idea is that it is local, that it is therefore focused on the needs of local populations as opposed to the potentially across the board approach that you might take if you looked at the whole population of Warwickshire, for example. But the delivery model has single neighbourhood providers, but also multi-neighbourhood providers. So, for example, you could see all of primary care across North Warwickshire or South Warwickshire coming together more on a place basis. So single neighbourhoods, generally 50k population, multi-neighbourhoods, more like the 250,000 population. But in areas like central London, the numbers will be slightly different.
Okay. Need to keep things moving, guys, because I've got a lot of hands up now, and out of time. Ian?
Yeah, thank you, Glenn. Very comprehensive, and it's really good to know that you're involved at this level. I just wonder how much of it is politically motivated, and should there be a change of government, whether things might take a different course?
Yeah, that's a good point. I mean, I think actually if you look at the mission shifts, they're consistent with lots of different flavors of government we've had over the last few years, and we haven't quite pulled it off. So yeah, everyone agrees that we should be more focused on health than illness, i.e., more on prevention and treatment. Everyone agrees we should be utilising technology. Everyone agrees that we should be trying to treat patients as close to their home as possible. So I think those mission shifts are absolutely consistent. There will always be a little bit of politicking at the edges of all of these things, and maybe for another day I could share some stories about that political interface and how it works or doesn't in some cases. But I'm pretty confident that what you see as the main thrust of this plan, particularly the development of neighbourhoods, that's got so much primary care buy-in and partner buy-in, that I think it's more about the service and the clinicians that will drive that than any kind of political wishes. The politics then often comes into play on how much resource we have to play with and what kind of different types of involvement of independent sector, for example. But I think the whole mission is very much a clinically led set of priorities.
And finally, thanks, Ian. And finally, David, then we'll move on.
Glenn, thanks, Russell. Glenn, you mentioned creating a new mechanism after governors are removed. What is it you're trying to hang on to when you do that?
Yeah, so I think one of the main reasons why there's a view that we should move away from governors elsewhere is that sometimes governors have been involved in transactions and maybe have stopped some things happening that may be for the greater good because they've been focused on their organisation. But actually, I think our governors bring that kind of real life patient experience and accountability for us to our community. So I think we need to draw people from our community. We need to ensure we've got channels of communication, and we need to be clear that we're being held to account by the people who use our services. So I think it's those things. So it's patient experience things, but also accountability things that I think we need to make sure that we get right. And particularly as we move into things like neighbourhood healthcare, we've got to make sure that we've got a kind of minimum set of standards that we never veer away from, but then also that we adjust services to meet those local challenges because they are slightly different. So the only way we'll know whether we're meeting them is to ensure that patients and public have a voice. So we've got to ensure that we listen to it.
Yeah, and I think also the only other point I'd add is when I look at a number of the governors who are even on this call, there's a phenomenal level of experience. You know, if I can use Jean Arrowsmith as an example, who's devoted a life to delivering healthcare in different circumstances and therefore provides a really helpful perspective. And over the years that I've been chair, I've always been singly impressed by the quality of the governors that Swift has been able to attract. So thank you. Okay, Tim, we'll move on. Glenn, you can disappear because you need to go and do some other stuff, I know. And we'll move on to the other areas of governor requested assurance. The first is the quarterly status update. Adam, what would you care to pull out of this?
Thank you. So I'm not going to go through this in detail, but I will draw out a few interesting points. Just as a refresh, this is a report we provide here quarterly. It shows our organisational objectives for the year and our status of delivery of them. It's aligned to the 4 big moves in our strategy and the supporting pillars, strategic pillars that support delivery of our goals as an organisation more generally. So this is the report for the first quarter. Obviously, the objectives were only set at the start of the first quarter, so you wouldn't expect these to necessarily be complete yet. Having said that, there is some really good work going on that I just want to highlight. So if I go through perhaps the big moves in turn, under the first big move, which is being a very flexible employer. I've skipped one out already. We've got some really good work going on with colleges and universities, and I think it's important from a number of perspectives. Firstly, in terms of developing career pathways for our staff, we know that attracting younger people into our workforce is becoming increasingly challenging as we see our workforce ageing. And so we've had some really dedicated work with local schools, local colleges and universities to develop plans, attract people through work experience and really support some of the apprenticeship work we're doing in that area. And those relationships with educational institutes are strong and strengthening. So I think great work going on there. In some of the other areas of flexible employer work we're doing, we've made some changes to rostering that have been asked for by our staff, including the length of time shifts are booked in advance and the number of shifts that staff are able to book. And that's really some of the prerequisite work to wider changes we're making about around self-rostering, people being able to select the shifts that they're able to work. So all of that together is really supporting our workforce in a different way and making us a more attractive organisation really to work for in Coventry and Warwickshire. If I do move on to the first domain, which is Home First, so this reflects really well some of the priorities in the 10-year plan that Glenn has talked about. And largely this is around our community services, our out-of-hospital services, and the way that we provide those services across Warwickshire. One of the biggest changes in the community services over the last couple of years was the development of the community integrator contract. And this was an arrangement where responsibility for provision of services as well as commissioning of services was passed to Swift. So we effectively are responsible for the whole pathway, or will be, on the full transfer of services. Over the last few months, we've been working on the transfer of some of the commissioning arrangements to Swift, and they are now on track for the first elements of that, which is the transfer of hospice commissioning, to come to Swift imminently. We've also been looking at some of the services we jointly run with the council, so the community recovery service being the predominant one there, which we've talked about here in the past. It's a service which supports discharge from our hospitals, and we're taking on the commissioning responsibilities for that service. So great work there. I think being responsible for the whole pathways allows us to think differently about how we run and manage our services. And so this is a first step to a wider journey at looking at community provision across Warwickshire. I do also want to shout out the work on virtual wards. We're in a great position for our use of virtual wards. We've gone up over the last few years from under 50 to, I think at the last count, 109, and still growing patients on a virtual ward. This ensures people are receiving the care they need at home. We know people get better quicker at home, but as importantly, if we've got 109 people on a virtual ward, that's 109 beds we're not using in a hospital. So in the context of the 35% increase in emergency care demand that Russell spoke about earlier in the meeting, you can really see the impact that virtual wards are having on supporting our services being sustainable. In terms of the prevention big move, we've had some great work on the wellbeing hubs we've established. We have hubs established at Lillington and at Stratford. Ellen Badger Hospital is open now, as we've said, and we've done some great work with the Stour Partnership on developing wellbeing hub provision there. It's a great building if you haven't been to it. We've also been working with partners across the ICB to look at greater use of population health management data. So there's a new tool that, as a system, we've invested in, which brings together primary care data, secondary data, and data from other sources to look at how we plan and manage our services to make sure we're really targeting care in the right place. And we've had some good work going on there as well. The third big move is around carbon reduction. We've had some fantastic work going on across the site over the last few years, which supported our green plan. Our green plan actually ended this year, but over the last few months, we've worked with partners to refresh that and relaunch it. It was relaunched a few months ago, and is our our commitment to sustainability over the coming years. Fantastic piece of work, which has been contributed to by a number of partners outside of the organisation. We're also looking at the work we do to provide paperless care for those who want it. Glenn mentioned the NHS app. That's a big part of our plans. We've also implemented a patient portal, which we've spoken about here before. And over the last 6 months or so, we've grown the amount of information available on that patient portal and indeed through the NHS app, while ensuring we still have paper-based means of accessing information for those who wish to have it. In terms of the strategic pillars, so the other things we do that support our delivery as an organisation, I think there's just a few things I want to pick out from there. So the first, and perhaps one of the biggest pieces of work we've got going on as a trust at the moment, is our implementation of a new electronic patient record system. So we procured the Cerner electronic patient record system. We commenced the implementation of it back in May. It's a over a year-long implementation. We'll go live next October. The first stages were about looking at how we work now. The stage we're in now is looking at how it's called localize the system to ensure it supports the way we work. It's one of the most important stages of the programme. The EPR is incredibly challenging. You will have heard stories about challenging EPR implementation programs elsewhere. It involves all our staff across the organisation. It involves a significant transformation to the way we work. It's an incredibly risky program. It is on track at the moment. It has huge benefits if we get it right, but we need to put everything we've got into it over the coming 6 months and year to make sure we do get it right. And the team are looking really closely at that.
Need to watch the time a bit, Adam, please.
Thanks. I'm almost finished, Russell. Just a couple more things to mention. We have been working with George Elliott, as you know, on establishing a shared leadership team. I'll talk a bit more about that later. But one of the primary reasons for this is about looking at sustainability of the two organisations and bringing our corporate functions together, which is one of the objectives we have for this year. We've already done that in some services, and we'll be looking across the organisations to understand where we can sensibly do that over the coming 6 months. There are some other good objectives on there, things we've already mentioned, the integrated healthcare organisation, work around pathway transformation, but I'll leave it there and take any questions.
I think that's great. Thank you, Adam. Just a couple of questions because we are running behind now. Callie? Callie, we can't hear you. Okay, are there any other questions?
Sorry, I was trying to unmute Russell. Apologies. Right. Okay. I just have 3 questions really. Obviously, I'm quite pleased that you are the Commissioner for Community Services, because commissioning is very important in delivering integrated care. I just wonder what's happening with other partnership initiatives that you mentioned in this report, because partnership working is essential, and sometimes, obviously, yes, you have the acute provider collaborative, all that sort of thing, clinical liaison groups, but when it comes to providing integrated care alongside the ICB, etc., how do you go about it? Because that's where problems arise, basically, when there's no integrated care.
Sure.
Thank you.
Obviously, this is still pretty fluid, Callie, as you'll appreciate, because we're in a process of waiting to see what an integrated healthcare organisation looks like. But quickly, Adam?
Yes, we've got what's called a care collaborative across Warwickshire at the moment. That's a committee of the ICB, but it's made up of representatives from primary care, secondary care, voluntary sector, social care and other partners. And for those key commissioning decisions, we work together through that committee to ensure we're really working in collaboration. As Russell says, it's still developing and will continue to do so, but it's a great mechanism for integration.
And Callie, a second question?
Yeah, there is something in this report, you going for an integrated health organization bid. I just wonder what's that about. Thanks.
Okay, Adam, can I handle that? Glenn handled that in his earlier presentation, Callie. The details of the integrated healthcare organisation are being developed, but it will provide us with more commissioning responsibilities. But if you want to have a look back in the early bit of this today, because I know you joined late, Glenn covered that off. And your final question?
Right. The neighborhood teams, all right, I don't know, is there information about neighborhood teams on the ICB or website, or how they facilitate the process to deliver better care? That's all.
We did cover that a bit with Glenn, but Adam, is there
Okay.
anything you'd like to add?
Well, I mean, what I'd say about those is they're still being developed, and even as we speak, there are workshops going on in each of the 3 Warwickshire places to define what a neighbourhood team looks like. They're different according to the neighbourhood and the neighbourhood's needs. But I think when they're a bit further along in the journey, we can perhaps come back here and do a bit more of an update.
Okay,
I'm sure
thank
we'll
you.
do that. No, thank you, Callie. Okay, team, just given the time, because we are running late, we'll move on then to the patient experience annual report for last year. Ellie, I know you're taking that as read, but anything in particular you'd like to pull out?
Thank you, Russell. Just a few things relating back to the 10-year plan and the NHS app. We currently collect our FFT through a third party, but the future plan for that is that people will be able to give feedback through their apps. So we're watching that space at the moment. There's a move away from PALS and patient experience as separate entities, and us having one patient experience team. So we're looking at that, not just locally, but across all the trusts in our group as to what that might look like. Our complaints rate has gone up, our formal complaints. However, as alluded to by yourself, Russell, and by Glenn, the people we are seeing, the numbers have climbed quite dramatically over the last couple of years, and so that needs to be taken in context with the 300 people we see in our ED every day, the thousands of inpatients we have, etc. So although that has risen, it's kind of risen in line with the number of people that we're seeing. I also always like to pick out the volunteers section of that report, because our volunteers are amazing. I think there's such a breadth and depth of volunteering goes on. I know we've got a governor's report about patient experience groups, so I won't say anything more about that, because it's a really good report. And so apart from that, it's any questions really, Russell?
No, thank you, Ellie. I'm always very conscious, although Swift is amongst the very best performers in the NHS, we do get things wrong. People do wait too long, despite the endeavours of Sissy and the rest of the team in ED, and Rachel and others, too long in ED too often because of that increase in demand. Radiology, I know there are delays in turnarounds there quite often. So despite the overall angle that Ellie's indicated of a very positive patient experience, we do recognise we don't always get things right. Any quick questions from members of the Council of Governors? Leslie, you're on mute. Leslie, you're on mute.
A compliment to say I was really impressed by the list of lessons learned. I thought that was excellent.
No, thank you, Leslie. And I think one of the things that makes Swift special is, almost going back to my earlier remarks, we don't think, even when we're doing well, we don't think we're doing well enough. And that's a mindset. It's part of our culture. We pat ourselves on the back, but we don't become self-congratulatory. We celebrate successes, but we also are very open about our failures. So, Leslie, thank you very much for those comments. We'll move on then. And I know, David, you've had some technical problems.
Yes.
But in terms of the clinical governance assurance report, what would you care to pull out?
Not really. I mean, these are for the 5 months, I think, meetings of April, May, June, July and August reports to the board. And I'm quite happy to take them as read and answer any questions people have got about them.
David, that's great. But just in terms of how, you are one of the most experienced commissioners and GPs in the whole of the county.
How nice of you to say that.
No, it's okay. I didn't like to say old. But given your experience and your the way you've seen things. How do you feel we're doing in terms of clinical governance and quality and safety?
I think the most important thing that we've got at Swift is the culture. The clinical quality is the paramount thing, and actually it's the thing that drives most of the decisions that we make, which I'd like to think was true at every trust in the country, but I know very well isn't the culture. And I think I came back just as I heard you saying that the one thing that we're very good at is that we never believe we're good enough. We're always aspiring to be better, even when on a lot of the indicators we're doing exceptionally well. And so I think that's one of the key pluses that this trust has got. The other thing is that it's very open. I have to say, if I ask particularly the clinicians for any information, they as rapidly as they can give me the answers, and it's quite gratifying to know that they'll do that. I think there are going to be some challenges in the longer term if we do become an integrated healthcare organisation, because of course the number of organisations involved is so much greater, and it'll be so much more difficult to be absolutely certain of the quality at every element of that. But if I have anything to do with it, I would like it, the culture of Swift to be the culture of any future IHO, and you can take from that I've got ambition for the IHO.
Thank you, David. Just got a time for a couple of questions. Callie?
Right, thanks, Russell. Right, I know there's loads of audits must be taking place, clinical audits taking place across the trust. Either have to do with NICE guidance or national audit projects or whatever. Are these reported to the Clinical Governance Committee, and do you get the overall picture? Do you monitor them basically, how well they're doing?
Yes, I mean certainly every division that if you've ever been to any of the clinical governance meetings, we have a rota, if you like, of every division in the hospital actually providing a report, and in that report there is always a list of the audits that they are doing, the audits that they haven't completed, and also a review of NICE guidance, whether people are compliant or whether people are not compliant to NICE guidance. So the answer to your question is yes, we have a very good overview of that.
Yeah, that's great. Thanks.
Thank you, Callie. Thank you, David. We'll move on just given time. And I'll say a few words later, Kim, but the financial situation is obviously very difficult for us this year, isn't it? These block contracts are really, I'd use a technical accounting phrase, clobbering us, given the way that they haven't been adjusted to recognise the increase in demand we've touched on. So, Kim, we're talking about month 4, but things are looking pretty challenging at the moment, aren't they?
Most definitely, that's correct, Russell. So we are struggling, I think, with the current financial regime. Those of you who were on the call earlier will hear that, about the work that Glenn is trying to do nationally, really to ensure really that we get paid for what we do. Currently, we don't. We're obviously seeing that 35% increase in demand, but we're actually not getting paid for it, and that is having a massive impact in terms of our financial position. So just to recap, we set a real stretch financial plan for the organisation, £2.3 million surplus. Now we did that in order to try and help the system, the Coventry and Warwickshire system, to try and get into a better financial plan in order to secure deficit funding for the system, and it was on the condition that all the parties within the system did their part really to secure that. Already everybody is feeling the pressures and struggling to manage the money, and as a result the deficit funding has been withdrawn from the system, and that is causing cash problems and pressures within the system.
So cash is intrinsically linked to your IME position. Now let's just remind everybody, our statutory duty as an NHS Foundation Trust and an NHS organisation is actually to deliver a break-even position. Now, the year to date, the month 4 position, we do have like a deficit plan, and the expectation is that as we progress into the rest of the year, we will deliver on our cost improvement programme and actually deliver that planned surplus. But the month 4 position, we're expecting to deliver a £1.8 million deficit plan, and we are off track. We have reported a £2.6 million deficit position. Now, within that, we are, for our overall plan, delivering a CIP of about £23.5 million. And we have identified all of the schemes and plans on how we would deliver that. The challenge is obviously, given the operational pressures, is actually to ensure that we find the time to give it the focus that it requires to actually deliver that and manage the money. Now, what we've done as an organisation is set up a financial recovery board. So, and each of the work streams is led by an executive director, and each executive director will have a work stream leads that will support them in terms of delivery. And the financial recovery board is made up of all members of the board of directors, so that there is more dedicated time to focus on those big projects and unlock any issues that are delaying us in terms of delivery. So it is a real challenging position for us. We need to try and get through this financial year in order to reap the rewards, really, that we can see that pot of gold, I suppose, in the future, really. So that's the challenge. But we need to make sure that we're doing the right thing as well at the same time. While we're balancing the money and the quality and the performance issues that we've got as well. So it's a real challenge for us. I don't think I've got anything else to add, Chair. Thank you.
No, thank you, Kim. Just to put what Kim's been saying, Kim, correct me if you think my numbers are wrong, but we at Swift are doing about £10 million of healthcare stuff that we don't get money for. £10 million. If we were paid for the ED work and elective work on a true PBR basis, that would swing our numbers by about £20 million. So the current regime is really crippling us financially this year. And as Kim indicated at the end, it is that balance between doing absolutely the right thing for our citizens, but making sure we are financially sound, particularly as we do need to break even to be even considered as an IHO. This is our most difficult year financially since I've become chair. Any questions or perspectives from colleagues? Okay, I'll move on and talk about it a bit later. But the audit assurance report, Robert White's on holiday this week, very sensibly enjoying the tundra, I think would be the right phrase, of Canada. Anything on the audit assurance report members of the Council of Governors want to ask? Okay, I can't see any digital hands raised, but thank you, Robert, for your leadership on that. So we'll then have some reports from governor representatives on projects and groups. And because we have so many apologies today, we're taking a number of these as read. And the first is the Community Diagnostic Centre project, which Mike Flaxman is the governor representative on. There's a 3-page report there, which I will take as read. Any questions from governors on that report? Can't see any hands raised. So we'll therefore move on to the Elective Hub project board, which David Fitzpatrick has kindly volunteered for. David, what would you like to pull out of this report?
I think there's just 2 things to add to the report and that great picture that shows the work that's been done. The first is to add my thanks to everybody who's worked on the project, both within Swift and outside, and also to mention that there is a date now for when it's anticipated this will be open with all the retail areas, etc., and that's Tuesday the 7th of October.
Thank you, David. Any questions or perspectives on the elective hub project? Really exciting development, particularly if you like Costa Coffee or Marks and Spencer's sandwiches or ready meals. Not, there are other retailers of choice, but not in our elective hub or reception area. We'll move on then to the Ellen Badger Hospital Site Redevelopment Group. Mike, what would you care to pull out of your report? Mike Ross.
Thanks, Russell. So I'll take the paper itself as read, but when I wrote it was a few weeks ago. And since then, UHCW, who provide screening services locally, have arranged to come and visit the site and check out the platform that's been built for scanners. So that's expected to happen in the very near future. Interestingly, the youth club from Shipston have started using the Health and Wellbeing Hub in the evenings on Tuesdays in the last 2 weeks, and seem to be getting on very well. We've also got a grant for PV panels on the roof, so that's going to be going on this autumn. And if anyone ever visits, they'll note, well, unless it's out, they'll notice that the community first responders vehicle is in the car park permanently charged. They have their kit on the top floor where the district nurses are, so they can stock it and get out quickly. And we're also looking, which I didn't mention, we're also looking for Shipston Home Nursing to be in the not too distant future. And again, the relationship between them and the district nurses, very often they're looking after the same people. So, you know, water cooler type conversations are easily facilitated with that.
Yeah.
Other than that, take questions.
No, thanks, Mike, and thanks for your enthusiastic support and endorsement for the Ellen Badger project. Any questions to Mike on that? And therefore move on to the End of Life Committee. And Michael, thank you for your involvement in this. Michael, what would you care to pull out of your report? Michael Coker.
I was unable to attend the first meeting, which is reported by Leslie, who went in my place. The second meeting, and that is there. I invite people to read that. As far as the second meeting was concerned, that was restricted to senior members of the committee, because it was a general review of what they felt was not up to standard and what they thought needed to be improved. I was very impressed that that was the view taken. They were looking for what was wrong, or more particularly what could be improved. I've always been very impressed by their work, but they're looking for something better, as you said. And they gave various jobs to various people, and they'll be coming back with how the service can be improved. As I say, as before, I was impressed by this committee.
Thank you very much, Michael, and thank you, Leslie, for deputising. Any questions or perspectives on the End of Life Care Committee? Callie?
Yes, thanks, Michael. Very quick question is the Striving for Excellence awards that are now in place, what that includes, who awards them. Obviously, there will be criteria for these awards, and is it like the teams within the trust, or is it like collaborative work from clinical teams from the community, Maidon Hospice, or whoever else is involved in End of Life?
Ellie, the Striving for Excellence Awards.
It's a form of accreditation, but we haven't called it accreditation because it will get confusing with ward accreditation. But it is our acute palliative care team that have asked to roll this out and pilot in some of our wards, asking for volunteers in the first instance and then rolling it across the other areas. But that's what it is.
Okay, yeah. So it's within the trust.
Correct.
Yeah. Okay.
Correct, Kelly. And you know, I think the general principle, and Michael, thank you for your kind words about the openness, which we've touched on a couple of times already in this governors meeting. But the reality is, self-evidently, two things you can be sure of: death and taxes. Is we're all going to get to end of life, but with an aging population, more and more of us are getting to end of life. And therefore, this is one of the big strategic and operational issues we face. How do we ensure that we're able to provide dignity at end of life for every single person in Warwickshire? That's the ambition. Being an integrated healthcare organisation will help us in that ambition. So the work of this committee as it goes forward is even more important. So thank you, Michael. Thank you, Leslie, for your involvement. We then move on to the Falls Prevention Steering Group. As I mentioned, David G is unwell, but Ellie, generally, it was due to be a verbal update. Generally, in terms of falls prevention, Ellie, how are you feeling about things?
Thanks, Russell. So the strategic meetings are going on. We've reviewed our PSERV objectives. We continue to see a good reduction in the number of falls, but what we are now seeing is an increase in falls with harm, which is really reflective of the frailty of the patients and the acuity of the patients that are falling and the reasons for falling. So we've got a number of really good work streams to further reduce falls in our hospitals when we're looking after people. And our falls lead has done some really excellent ward-based work and training. So we have a set of, we're quite unique as a trust, we have a set of falls prevention competencies, which we ask all our registered staff to do. And then we've also now rolling out those for clinical support workers as well. So there's a lot of really good work streams running through that meeting. And we are, of course, being held to account by our Patient Safety Surveillance Committee in terms of our PSERV plans and actions.
No, thank you very much, Ellie. I would make a general point to members of the public. The old phrase, move it or lose it, is very relevant when it comes to mobility as you get older. So I'd really encourage you, if you are, Callie, could you go on to mute, please? Thank you. I really would encourage all of us as we get older and a little bit more frail and we see our muscle mass reducing, to just try and do some simple strength-based, even sitting down activity. Don't feel embarrassed to use a walking stick. A walking stick should be an appendage of pride and good sense, because the worst thing that can happen as we get older is to fall over. And the final thing I would say to members of the public and loved ones who are in the hospital, if one of our nurses tells you to seek assistance when getting up, if you need to go to the loo, seek assistance. Don't try and do things on your own. That's when it's really easy to fall over. And as Ellie's indicated, if you are a little bit more frail, that's when breakages and more serious damage can occur. So David, we wish you a speedy recovery. We'll move on then to the Health and Wellbeing Hub Steering Committee. Touched on this a little bit already, Mike, but back with you.
Thanks, Russell. So I'll take the report as read. There's lots going on, and so I'd like to do a couple of thank yous. Know that Rowena Webb from Star Health and Wellbeing Partnership is with us today. So a big thank you to the partnership for everything they're doing at Ellen Badger. It really is their sort of spiritual home now, and there's loads going on. It's great. Warm hub today. Toy library was open, play and stay, all sorts. And also to Karen Parker, who is the Health and Wellbeing Hub Manager, and her team. They're doing excellent work around the patch on all three sites.
Okay, thank you very much, Mike. Any questions on the Wellbeing Hubs Steering Committee? Callie?
Thanks, Michael. I just there is something in the report about difficulties with the lack of budget. Is that has to do primarily with the ICB, or is anyone else involved? How can things improve financially? That's all I'm asking.
I'm just trying to see where in the report that is, Callie.
It says, sorry. Unless I'm sure I'm reading the right report. Yeah, Health and Wellbeing Hub Steering Committee meeting, and it's under the collaboration and coordination. That there is a paragraph that says
the bottom one, yeah.
Yeah, that's what it is.
I don't think there's a mention of budgets, so that was my confusion, Callie. Adam?
Yeah, penultimate paragraph on page 71 of the pack, Russell. There are difficulties with lack of budget. So this relates to the general financial challenge we've got across the trust. I think we've been lucky to put some one-off funding from other sources towards this. In the past, we had a grant from the council last year. We've been able to use our charity this year, and we'll continue to do that. But of course, those are short-term funding sources. I hope in the future this is something we'll be able to make more sustainable. At the moment, there is a service offering based on that, though. But we always want more because we know the good work this service does.
Yeah. And I think, again, just to reiterate what I said to governors earlier, we're doing about £10 million of stuff which we don't get funding for. And this year that's proving very, very difficult, and we're having to make some tough decisions. We'll move on. That's what I thought. Thank you, Sarah. We'll move on then to the Medication Safety and Optimisation Committee. This is Tim Crooks, who's not able to join us today, so I'll take that as read. Any questions on the Medication Safety and Optimisation Committee? Ellie, if you could put your hand down, that would be great. We'll therefore move on to the Patient Experience Group. And Holly, what would you care to pull out of this? Holly, you're on mute.
Sorry, I was struggling to find the unmute button. It was Manu who attended these meetings this time. I was unavailable, and I don't believe he's here today.
Okay, now I thought Manu was on the line a bit earlier, but maybe I imagined that. So we'll just take the report as read then, Holly. Any questions on the Patient Experience Group report? Can't see any digital hands raised, so we move on then to the Patient Safety Surveillance Committee. Always worry when the word surveillance comes out, makes you feel as though you've been monitored by CCTV everywhere. I'll take it as read, given Carolyn's not with us, but any questions on the Patient Safety Surveillance Committee report? Can't see any hands raised, so even more worrying given the title, the Radiation Protection Committee. Paul isn't with us today, so
yes, I am.
Oh, sorry, Paul.
Yeah, I'm just unmuting myself. Yes, I put in a written report, very short, because there's only been one meeting of the RPC. I'll just briefly summarise it in case people haven't read it. There was only 1 out of 16 incidents in the last 6 months, which was reportable. In this particular case, the wrong patient was treated when a husband and wife were confused. They resided at the same address, no surprise there. They had the same, they'd given the same date of birth, and they had almost the same name. And something to be aware of is that in some cultures, only the year of birth is considered important and not the day and the month. Otherwise, another incident was that some images were taken but couldn't be found, so a procedure had to be repeated, which isn't desirable. But it transpired that the images had been quite simply filed in the wrong folder. And a number of referral errors had been identified, which had resulted in the wrong part of the body being x-rayed. The CQC was satisfied with the situation. Its only concern is the time taken to report incidents. And the next RPC meeting is on 3rd of November. That's about all I can tell you, I'm afraid. I hope that's something.
That's very, very helpful, Paul. Quite like the idea of your year of birth being important rather than the date of birth. Questions and perspectives to Paul on the RPC? Thank you, Paul, for your diligence on that. Then we've got the Safer Discharge Group. Jean, I wasn't expecting you to join us today, as I know you've got some pain management challenges yourself, so thank you for joining us. But Jean, is there anything you want to report on this? It's got nothing to report on the agenda.
Their meetings, because they're every other month and as are as well, didn't quite coincide. But I can reassure everybody that Ellie leads it exceptionally well, and everybody's really working hard at it. And we thank the blood bikers. We've just got some teething problems in the way that is handled by some wards and some people. So we're just tidying up the ends on there. But other than that, pharmacy attended the last meeting, and that was a great help. Because they've been missing for quite some time, so we need to know and to support and to talk to them. So all in all, really a lot of work going on there, and it's positive. It's not always right, but it's very positive in the way it's been managed and handled.
Thank you very much, Jane, and thank you for your perseverance. Any questions to Jane? Can't see any hands raised. So we'll move on then to the Salix Project Board, and this report to be taken as read. Any questions on the Salix Project Board report? Holly?
Just a quick one. Is there an opportunity to be able to look at the monitoring of the impact of the changes that have been made, particularly at Warwick Hospital? And is that publicly available? Because it'd be really nice to see.
Adam?
Probably early days yet, but what we will do in due course is review it through our improvement board, Holly, and we normally do that either 6 or 12 months post implementation. So when we do that, then I will make sure it's shared with governors.
Great, super. Thank you, Adam. Thank you, Holly. Colleagues, happy to move on to the Serious Incident Review Group. Jim?
Okay, thank you, Russell. Nothing to report really, basically because it's been stood down. The executive team have, there's a lot of duplication, there's limited reports coming through on patient safety, so it's been stood down and nothing to report. Thank you.
Thank you, Jim. Well, given it's been stood down, there's nothing to report, so no questions to be asked. I guess apart from David, as chair of the Clinical Governance Committee, are there any serious incidents which you're aware of, which you think the Council of Governors need to be made aware of?
I don't think so, no. Certainly not in the recent past. We've been remarkably free of serious incidents.
Okay. Having said that, experience dictates there will be serious incidents.
There will be, yes.
Okay.
Yeah.
Thank you, David. We'll move on then to the Wayfinding Strategy Group. And I know Roger, a previous colleague of ours, as a Council of Governor member, did an awful lot of work on wayfinding. Roger's under the weather, so Roger, we wish you a speedy recovery. But Mike, anything on the Wayfinding Strategy Group that you'd like to mention?
No, I'll take the paper as read. The only thing that I will feed back to Michael Cox, who was the author, was that at our meeting this morning, Holly suggested a group of volunteers who should be engaged with for their opinions. So I'll make sure you get that info.
We are using Living Map now, aren't we, Adam? Yeah.
We are, yes. There's screens up in a number of places around the hospital, and there will be one in the new hub when it opens as well.
Okay, super. Okie dokie. So we'll move on then if there are no questions on wayfinding. It's always a nightmare when you come to hospital, you're stressed, you're worried, you're anxious, and then you've got to find your place, find your way to a different area. And we know how, if you like, suboptimal the layout of Swift is. The wayfinding work is disproportionately important. We'll move on then to governance matters. And first up then is the GPC approved minutes from the 10th of April and the 10th of July. Mike, anything you'd like to pull out of these?
No, they're self-explanatory, Russell.
Any questions from colleagues? I can't see any hands raised. So we're then on to the Patient Care Committee. Approved minutes on the 14th of April, 12th of May, 9th of June, 14th of July, and the meeting report of the 11th of August. A full 41 pages, Jean, you're being greedy. Jean, anything you'd like to pull out?
No, just to make sure that everybody's been advised that we've changed them to bi-monthly. So they're not every month now, they're every other month, it used to be like that pre-COVID. I'm not sure why it changed to monthly, but I think it's a bit hard on David and on Ellie and Fiona that they were every month. And so I'm really pleased that the committee have accepted my suggestion. So that will be our way forward.
Okay, thank you, Jean. I think we put it in place just to make sure the members of the public felt that there was an opportunity for scrutiny. Any questions or perspectives to Jean? Kelly?
Yes, Jean. Probably I didn't ask the question earlier on when I was looking at the Clinical Governance Committee, the Trust Committee's report. There is something about increasing trend of incidents reported with harm, and that there's going to be a deep dive into what's happening with these trends of incidents with harm. What is your view on what's happening with these incidents? And
so Kelly, which page are you looking at? Because obviously we do deep dives into every single incident with harm. What page are you looking at in the pack?
It didn't identify which incident. It was I don't know
which page in the pack?
It is in the Clinical Governance Committee report that Dr. Sprague referred to. And obviously, I can't find the page in Jean's report. But I just was wondering what's happening with these incidents.
Yeah, I mean, we do deep dives into all of them, but David?
Yeah, I mean, just to clarify on that, the important thing here is it seemed to have coincided with a change of the reporting mechanism, and the deep dive seems to have shown that one of the options that you don't get with the new reporting mechanism is near miss. And so some people are actually reporting near miss as low harm, which of course potentially it could be low harm. Probably the assuring thing is that the national sort of average for low and no harm incidents reported is 93%, whereas in our case it is 99%. So actually we are way above the national average for that, and one might argue we're slightly underreporting on that basis. So actually we're very assured that we're not having any more harm incidents than we would be expected. So I don't know if that answers your question, Callie, does it?
Yes, it does. Thank you. Cheers.
Thank you, David. Thank you, Callie. So if there are no other questions to Jean, we'll move on then to the report on resignation and appointment of governors. Sarah.
Thank you, Russell. So I think the report's self-explanatory, and as you noted earlier, unfortunately, Sue Warner has submitted her resignation as a staff governor. So we now have 3 vacancies. I'm happy to take it as read, and if there's any questions, thank you.
Thank you, Sarah. Any questions or perspectives on that? And then Ben, over to you for the external auditor's annual report. It's clearly been a bit of a challenging year in terms of the audit, but Ben, over to you, please, for your external auditor's annual report.
Thank you, Chair. So this report is our auditor's annual report, which goes alongside the audit opinion itself upon the financial statement. So the audit opinion is included within the annual report and accounts document, and that gives opinion on the truth and fairness of the financial statements. This report is a document we are required to do, setting out our value for money commentary, which is our work looking at the trust's arrangements to secure economy, efficiency and effectiveness in the use of resources. I just emphasize that because the purpose of it is not to give an overall conclusion on whether the trust achieves value for money, but to look at the governance processes and arrangements around that to try and achieve those outcomes. So that is the main focus of the document, although we also touch on the outcomes of that financial statement audit work. And as summarised on the executive summary, we issued an unqualified opinion on the financial statements, and we didn't report any significant weaknesses in the trust's BFM arrangements. So then that's the clean version of reporting from these purposes, and so then the rest of the document is talking about our commentary of observations we've made from our work. I think points I would highlight from that, and consistent with some of the things you've been talking about already, clearly the financial position for the trust and for much of the NHS is challenging. We look in on the financial sustainability side. We look at both how the trust has performed during the year, so the year to the 31st of March, but also the arrangements it has been putting in place during that financial year as part of its planning for the following year, so the 25-26 year that we're currently in. But we don't then look at things that have happened after the year end in terms of sort of ongoing process from that falls into next year's considerations. So we have some commentary in here on how the trust had performed and some comparisons of that to other organisations, and how the process of setting the trust savings plans for this year had gone during the financial year, and process around the budget, some observations upon that. The second area we look at is around governance and oversight, risk management, those kinds of areas and observations around those. And we had some recommendations reflecting the increased complexity of the group following the transfer that happened with the estate during the year from the trust itself to its subsidiary Sept Clinical Services, and that has made some of the financial accounting and reporting processes more complicated, and some of that needs work to embed new arrangements in a robust way, and we've made more detailed recommendations to audit committee and management on that. And alongside that, had made some observations on process around some of the more complicated things the trust is doing, and on capital expenditure. The third area is labelled as improving economy, efficiency and effectiveness. So what the trust is doing to identify opportunities for improvement in its services and its operations, and how it is collaborating and cooperating with other organisations, both as part of the foundation group in your case, but also with the wider system, and clearly with the changes happening in the NHS, or that goes outside of this period, that the sort of changes happening with ICBs and how they're working, changing relationships within systems, and developments of what the trust is doing in terms of board this year. Those are all kind of things that will be an area of focus for us looking at this next year. Our recommendations then summarised together in the appendix to the report. But we'll be very happy to take any questions from governors upon this.
Thank you, Ben. And can you please pass our thanks on to all members of your team who have been involved in the project? Any questions to Ben? Okay, thank you, Ben. So I think they were on to any other business. Any other business from colleagues? Just one from me. Kim Lee, our Chief Finance Officer, who's I've worked with and known for all of the time I've been here. I think it's 8 years since. Can we go on to mute, everyone, please? It's been, I think, 8 years, Kim, that you've been the Finance Director or Chief Finance Officer. Kim's decided to retire at the end of this month. I'd just like to say on public record, Kim, my enormous personal thanks, and as Chair, our corporate thanks for all of your hard work over all of those years. Swift has a quite remarkable record of financial delivery, and that's been associated with you being in that Chief Finance Officer role. So on behalf of all of us as a Council of Governors, we wish you a very happy retirement and much happiness going forwards. Jean, your hand went up after I started. Did you have any other business?
Yes, sorry, I pressed it and it said it's not working. Do it again. So just to say, everything is in my regards anyway working, and I just wanted to leave everybody with some good news. I've been admitted 4 times in the last year for pancreatitis, and I've now had my cholecystectomy. But I've really got to know the wards, and on every occasion they were excellent, and I made a point of speaking with the sister or nurse in charge to tell her so. I saw a GP this week, and they prescribed some drugs for, I think I've got a compressed nerve in my spinal. But anyway, the pharmacy agreed to, requested them, and they agreed to dispense them immediately. The OTs came round this morning and stayed for a couple of hours. And they couldn't, they complimented the GP surgery and the hospital. They also referred to how they get referrals from the fire service, from people who've got nobody at home, and nobody realises that until they get dumped back home after they've been admitted to A&E. I mean, I won't go on, but it's all positive. I've had a lot of experience of of Warwick Hospital and our GP surgery, who are absolutely excellent. I can't fault them. So I just want to say thank you, and to reassure everybody that although there are things, you can't have perfection without keep trying. So I just want to say thank you.
Thank you, Jean. And Michael? You're on mute.
Pleased to see Jean, but the question is there some way we can stop Kim retiring?
That's a lovely thought. I think Kim's deliberated over all of her options, and we wish you well, Kim, rather than put you under any more pressure. You have a lovely break. You deserve it. And Jean, we wish you a very speedy recovery. Any questions from governors? Any questions from members of the public? Sarah, have we, or Verity, have we been told of any?
None submitted in advance, Russell.
Okay. Anne, would you like to ask a question?
Yes, I really would. You have spoken twice and said we're doing £20 million worth of work and only getting funded for 10 million. What does this refer to? And it didn't sort of crop up in Ben Sheriff's audit, unless it was sort of in financial terms that I just didn't understand. But you said it twice.
Okay. So just for clarity, and in terms of what I said we're doing about 10 million worth of stuff which we don't get paid for. So we do an awful lot of community related work, which is on effectively a block contract. A block contract means we're given a lump of money, and if we do more work than was calculated in that lump of money, we end up effectively subsidising the contract. So we do a lot of that. We've done a lot of that over the years. So Swift was one of the very earliest trusts to set up a discharge to assess pathway where we would put interim beds in place for members of the public, which we were never funded for, but we knew it was the right thing to do for our citizens. The 20 million is a different 20 million. That 20 million refers to a combination, but mainly what's happened with our emergency department funding is that is again a block contract. But over the what normally happens in an ICB, and Kim, if you think I'm being inaccurate, please interrupt. What normally happens in an ICB is every year they calculate how much emergency department work they expect the acute providers to do. They give them that money on that expectation. And if at the end of the year that has been incorrect, they adjust it for the following year. Now, what's happened in our ICB is there has been very little adjustment for the emergency department work. And in our ICB, there has been an enormous shift in work of the 35% increase for us, but a decline at UHCW. Now, that number is around £20 million. So it's the way the current financial regime works. In the past, there used to be something called payment by results, which is a misnomer, but it basically meant the more work you did, the more you got paid. And that's the piece of work that Glenn Burley is currently working on nationally, and I think will be really important if the NHS is truly to reward those high performing trusts and to expose those trusts that aren't performing well enough. Hopefully, Anne, that's a bit of a clearer explanation.
Thank you very much for that. Thank you, Russell.
That's okay. And Kim, what I said was broadly correct, wasn't it?
Yeah. Yes, most definitely.
Thank you. Okay, team. We will therefore draw this meeting to a close. I look forward to seeing you at the next Council of Governors meeting, which is in November, but we will take a 5-minute break, Governor colleagues, and get back together for the confidential session in 5 minutes at 3:45. Look forward to seeing you then. Take care, everyone. Bye-bye.